Good afternoon. My name is Susan Haas. I'm a physician working in the Health Services Engineering Institute at Northeastern University in Boston, Massachusetts. My topic for this webinar is Choosing Wisely, a program to reduce unnecessary medical care. My role in the HSYE is called Clinician-in-Residence. In this role, I work side by side with health systems engineers on improvement projects in inpatient and outpatient settings. I also teach how financing and culture impact operations, including the impact of the Affordable Care Act. The problems with the United States health care are well known to everybody on this webinar. It's too expensive, it's dangerous, it's not equitable, there's too much health care and too much variability. All of these are well documented, and I'm not going to go over all of them. Choosing Wisely addresses these latter two, too much and too variable, and we are going to explore those. Turning first to the question of too much health care. The waste in U.S. health care, defined as spending on activities that do not benefit patients, is widely estimated to be at least 30%. And this recent paper from 2012 by Don Berwick summarizes this. In fact, he found a range of waste that went from 21% to 34% to 47% if you took the most conservative, the mean, and the least conservative measures of what constitutes waste. In the same year, the Institute of Medicine published their estimate of waste, and they came up with 28%. So these two highly regarded authors came up with really the same estimate. And this pie chart shows where the major categories of waste are, and we're going to focus today in more detail on the blue slice of pie, the unnecessary services, as well as the red inefficiently delivered services. That is the approximately half of this waste that is really the subject of the Choosing Wisely campaign. To be a little bit more specific about too much, some tests and procedures are unnecessary and even harmful to patients. And we have developed this wonderful phrase, a medical ecology, based on overprescription and overconsumption from both physicians and patients. So it truly is an ecology. And it centers around the concept if some medical care is good, more must be better. To look at a specific example of too much, this is a format most people have seen from Consumer Reports. Consumer Reports rates consumer products. For example, in Boston, we've been looking at snowblowers in great detail lately on Consumer Reports, and it'll look at price, efficiency, how long before it breaks down, how quiet it is, cost to run it, et cetera, et cetera. And they'll rate different snowblowers on this range, through the red to the black, on highly rated on all those aspects of a consumer product to poorly rated. Recently, they've gotten into looking at healthcare, and here is a study, a process they did looking at various tests that can be done to screen for healthcare problems in symptomatic or asymptomatic patients. And you'll note that the most important heart screening test that you can get is a blood pressure. And the second most important and effective screening test is cholesterol. But at the other end, you'll see that cardiograms and stress tests are far less helpful and have essentially no benefits with some costs and some risks. So they actually did a survey of their subscribers, and they looked at 40 to 60-year-olds. These are not people who are 65 or eligible for Medicare. These are clearly middle-aged people. They had no known heart disease. They had no risk factors. In other words, nobody is a smoker in this group. And they had no symptoms. And they found that almost half of those patients had received some kind of a screening test that was ranked by Consumer Reports as very unlikely or unlikely to have benefits that outweigh the risks. So looking at the graph on the previous page, almost half of these healthy middle-aged people were getting those tests. Now, I want to review, because this terminology is helpful when looking at clinical care, 3 categories of clinical care in the terminology. The first is effective care, and this is any care where the benefits outweigh the risks. So an example here might be if somebody had a skin cancer, should you remove that skin cancer or not? And there's wide consensus that the benefit of removing it rather than letting it sit there outweighs the risks. And there is a known right rate for delivering that care to any patient who is eligible. And the right rate for delivering that care is 100%. If there's a care process that's effective, a patient is eligible for it, they should get it. The second category is called preference sensitive. And these are cases where there's more than one generally accepted treatment option available. For example, for some cancers, surgery or radiation may have equivalent cure rates. They may have different timings, intensity, slightly different side effects, but equivalent cure rates and equivalent levels of risk to benefit. And there's a right rate for this care as well, and that is whichever one the patient chooses. Okay. The third category of care, and this is where choosing wisely is very much involved, is what's known as supply sensitive. And in this case, the frequency of using this is related to the capacity of the local healthcare system. So, for example, if a hospital has one or more robots for doing surgery, and those $1.x million machines have a time available on them, there's an incentive to do more surgeries using the robot, okay? If you have a labor and delivery floor with more rooms than you actually have patients and plenty of nurses, there's an incentive to let people who really aren't quite in labor come in and occupy those beds, because then the beds are occupied. However, there is a right rate that we can define for the use of supply-sensitive care, because this isn't bad care. It's just that the use is really specifically should be for patients for whom the benefits outweigh the risks. Using a robot is fine, using a labor and delivery bed is fine, but it should be only for patients who warrant it in the first effective care category, not for patients who are available to fill up the space. And I would point out that these are on a spectrum, and that in all three categories, patient choice is usually affected by their professional opinion of the doctor that they trust. The second problem is that care is too variable, and we know that the rate of tests and treatments vary among doctors. This slide looks at, on the x-axis, about 322 orthopedic surgeons, and on the y-axis, how many total knee replacements they do per 100 patients who come in for a diagnosis of knee joint degeneration. And this is not just one visit, but a patient who has a series of visits and tests with or without surgery over a period of time. And you can see that the rate among these doctors ranges from about 0 per 100 patients to 65 per 100 patients. That's a pretty big range in a case where the patients are relatively similar as best we're able to risk adjust these patients. And when you look at this, there may be certainly some examples. Some of the doctors down in the number 1, 2, 3 group are about to retire. They're seeing patients in the office, but they're not operating anymore. And some of the patients at the other end of the spectrum are at tertiary referral hospitals where only the hardest cases from a multi-state area get sent to them. You know, when you sit down with the doctors and talk, there'll be reasons for some of these, but there isn't a reason that explains a tenfold variation across the board for this. But we observe it. Another example, instead of looking at care, is looking at spending. And this is a slide from the famous Dartmouth Atlas, with which I assume everybody on this call is familiar, in which researchers at Dartmouth University looked at the amount that was spent per Medicare patient across the country. And you can see that it ranges from about, let's say, $5,000 per patient per year. This is in 2003, it'll be pretty different now, to somewhere in the range of maybe 9,000 or 10,000 on average per year across the country. And the darker areas are those where the spending is higher. And you can see that the spending is higher on the East Coast, okay, New England, New York, on the east coast of Florida, in the Houston and Dallas areas, in Los Angeles, in San Francisco, in Chicago, Pittsburgh, Detroit, Ann Arbor. You can figure out where all this spending is. So this is cited as a classic example of supply-sensitive care. There's a lot of healthcare facilities, a lot of doctors, and a lot of more care there. In fact, in this study that was cited in the New York Times within the last month, looking at 2012 data, again from the Dartmouth Atlas, they looked specifically at nuclear stress tests, cardiograms, and vascular ultrasounds. Some of those tests that were rated with a big black circle in consumers' reports, and looked at where those were provided at much higher rates in the few years just before patients died. This study was interestingly opened, the article in the New York Times opened, citing patients from Massachusetts who spend the winter in Florida, where their cardiologist in Florida had these tests recommended, call back to their doctor in Massachusetts who says, no, you don't need that. And so this is a classic example where they're prescribed twice as often in Florida as Massachusetts. So why do we have this problem? The first example is really something that's called scope creep. And engineers are all familiar with scope creep because you start projects and it seems more to do a little bit, it seems good to do a little bit more and a little bit more, and the projects keep getting bigger. And the same thing happens in medicine. Part of this is because a lot of studies are done on very homogeneous populations, historically on men but not women, adults but not children, never pregnant women. And so doctors have patients in front of them for whom a study hasn't been done. So they can't actually know from the literature to apply that to that patient, but they have to treat the patient. So that's part of scope creep. But the other is in legitimate needs to try to care for patients where there isn't a test or treatment. And the classic one that's always cited here is a blood test called CA-125, or cancer antigen 125. It's a biomarker that's very helpful for women who are undergoing treatment for ovarian cancer, because when it goes up, the treatment is not working. When it goes down, the treatment is working. If it goes back up again, the disease has recurred. So very helpful in guiding treatment. The problem with ovarian cancer is that it's usually discovered very late. The treatments are very, very hard for patients and their families to endure. The majority of women die because it's discovered so late. So as you can imagine, everybody wants to find a test that will help identify patients who have early ovarian cancer for simpler therapy and a much better chance at life. So here's the CA-125. Patients come in, you know, my mother had ovarian cancer, or I'm worried, I don't have any symptoms. The test gets drawn, okay? And it turns out that the vast majority of abnormalities are false positives from other gynecologic or non-gynecologic diseases, but that requires more testing, sometimes requires surgery to be sure that there's no ovarian cancer. So this is a classic example of how scope creep occurs, trying to meet a legitimate need. The other problem is that in the United States, this is encouraged by financial incentives. The vast majority of doctors are paid on a system called fee for service. I do a service, I get a fee. I do another service, I get another fee. I do 4 services, I get 4 fees. There's always in the back of your mind this little tug with professionalism and what's right with the patient, with the fact that you're getting paid by how much you do, and it's just there. Doctors are human. Not all doctors are paid this way. There's increasing and very strong pressure to decrease the amount of care that's given by straight fee-for-service, but in Florida, in Medicare, that's where you can see it. And then the final part is the supply-sensitive problem with this variation in resources, such as testing equipment and hospital beds. So here's a perfect example of the merger of scope creep and financial incentives. This was actually in the New York Times just last week. This looks from the years 2005 to 13 at the number of operations that Medicare paid for to open blood vessels. In the black line are coronary or heart blood vessels, And what happened was that there was a lot of scrutiny because many of these procedures weren't necessary and didn't add benefit. So there's a lot of pressure within hospitals looking at doctors doing these procedures and pushing them to be sure that every single one needs to be done. And so you can see the rate go down in the black lines. What happens at the same time? The same doctors who are good at doing this in the hospital could also do it in their office where there's much less scrutiny, and they can do it on arms and legs, and they can do it on arteries and veins. And so the Medicare claims, which went down 30% for the heart procedure, go up 70% for the arms and legs procedure. So why do we have this problem? I'm going to move a little bit to culture. Physician training rewards ruling out everything that could be possible in a patient. So this is called hypothesis testing that focuses on the pursuit of true negatives rather than true positives. That's what our training focuses on. Make absolutely sure the patient doesn't have anything. Why would I not get a CA-125 on a patient asking for it with a family history? Fear of malpractice claims is always there. And physician training also instills this mindset that more testing is better care. Again, this comes from the academic training aspect. So one solution to this whole set of issues we've been talking about is choosing wisely. And I'm going to use their language because it was very carefully crafted. It's an initiative of the American Board of Internal Medicine Foundation, along with Consumer Reports, to help physicians and patients engage in conversations about the overuse of tests and procedures, and to support physician efforts to help patients make smart and effective choices. Very carefully crafted language. So this legitimizes the ability to cut back on what's unnecessary, and it also in particular focuses on areas of very high discretion. A little bit more of their language is that it promotes care that has evidence to support it, does not repeat tests or procedures, does not harm the patient, and is truly necessary. And then finally, again, this is very striking language. It encourages a just distribution of finite resources. They're saying very clearly there's only so much money to go around, which is not how we think of things in America. If you want it and you need it, you can have it, is kind of the American way. And they're saying finally, at 18% of GDP, there's not enough extra money. You know, this is cutting into education and fixing roads and fixing transportation systems. And we really need to start saying there's only so much, but how do we distribute it fairly? Okay. How this thing works, all the specialty societies, and I'll show you a list on the next slide, have created lists of things physicians and patients should question. Evidence-based recommendations. And as of January, 64 societies had weighed in. When you look at this slide, you can see this is everybody's in. The internists, the pediatricians, the surgeons, the radiologists, the oncologists, the obstetricians, the psychiatrists, occupational medicine, everybody's in, and you can see it. And some people are in twice. They've done their 5, and now they're doing another 5. So I want to look at one set, because this is pretty striking in the United States. This is the Society of General Internal Medicine. These are the folks that are the PCPs for most adults. Look at number 1. Don't do daily finger blood sticks, blood testing of glucose on patients who have type 2 diabetes but are not on insulin. Okay, that's been a standard way of patients keeping track of themselves, but it doesn't make patients any healthier. It doesn't help with determining when to change the dose of medication. So stop doing it. Do it when you need it, if you put a patient on insulin, or if you change one of their other medications. Look at number 2. Don't do annual exams. This is 40% of what these doctors do for a living. Don't do it. Because it turns out when you actually look at the evidence, it doesn't decrease hospitalizations, it doesn't decrease mortality, it doesn't decrease morbidity, and it leads to a bunch more unnecessary testing. Don't do routine pre-op testing before low-risk surgical procedures. The CARE, the classic example here is for cataracts. If somebody in your family is having a cataract operation, they should not have an EKG, they should not have a chest x-ray, they should not have a blood test, okay, if they don't have any other diseases that need to be evaluated. Don't do cancer screening in adults with a life expectancy of less than 10 years. Cancer screening is defined cancer when it's asymptomatic, when patients don't know that they have it, okay, and to do something to divert it on a long-term basis. In this case, these are patients who are generally frail. The testing has more morbidity in patients who are frail, and they're unlikely to live long enough to benefit from this, okay? So these are pretty big changes. So here's the process, and this is an important slide that all the societies went through. Every society determined for itself what their list of 5 was going to be, but they had 4 requirements. First of all, it has to be what you do, okay? Nobody but pediatricians can weigh in on vaccinations for children, okay? Nobody but orthopedists can weigh in on knee replacements. It has to be what you do, okay? It should be used frequently or have a significant cost, okay? So that's why that annual exam or those pre-op testing rose to the surface. There should be generally accepted evidence to support each recommendation. This shouldn't be based on one paper or somebody's opinion. This should be pretty clearly the agreed on quality literature. And finally, the process to reach this guideline has to be thoroughly documented and publicly available. So this is the core of how Choosing Wisely works. And then it's spread through consumer reports, AARP, Robert Wood Johnson grants, which there were 21, and there's a new grant cycle now out, and health systems leaders networks. These are pictures from various organizations. The one in the middle is from the Iowa Healthcare Collaborative. So lots and lots of organizations and medical societies and hospitals are spreading them. What happens is the hospitals spread them, they promote it to their group, the implementation of clinical decision support happens, but then people look more and more about what else are we doing that has a lot of variation, and they launch more quality improvement programs. And there are actually a couple of very cool apps that have been developed. So here's a great example of a piece of paper that goes straight to the patient, and they can get this anytime on Consumers Reports. Anybody on choosingwisely.org can access this stuff. I want to talk a little bit about the culture and interpretation, because culture matters in medicine. The concept here is understand the risks and benefits, not you can't have this. Okay? It's about having a conversation and understanding for you, the patient. And it activates professional autonomy. It says to the doctors, this is for you. This is not 1-800, you can't have this treatment or this drug. This is, doctor, you and your patient are in charge of this decision. It's also important to consider the bias of the societies creating the list, and the American Academy of Orthopedic Surgeons has been called out politely but very firmly, because they put in over-the-counter medication, little procedures, small pieces of equipment, but nothing that has well-documented variation and affects their revenue, such as we saw. And some societies named other specialty services, particularly imaging, and the reason that fits with the guidelines is that I order an ultrasound to be done by a radiologist, or I order a CT. So it really is in my purview whether or not I order it, even though it's in the imaging area. I'm going to skip through these slides, will be in your slide deck, the orthopedic surgeons, but these are the procedures and medications that I just recommended before. And you can see that they're much less significant than the procedures and medications on the earlier list. So we talked about some low-value care representing supply-induced demand for services, and that's especially true in the case of advanced imaging technology. So about 40% of the Choosing Wisely recommendations in the end were about imaging. This is a disproportionately American aspect of low-value care. Pennsylvania has more CT scanners than Canada. And here's just a visual looking at the first number of choosing wisely recommendations. Those in blue-gray up at the top left are all imaging recommendations. And you can see that many, many different societies are doing that. The reasons cited, one is about ionizing radiation, because there's increasing evidence published that over a lifetime of having ionizing radiation from radiology procedures, there's clearly an increased risk of cancers later in life, particularly when the radiation is given to children. So there's a very strong pressure to cut back on radiation now. To go through some examples of actual harms and all of that come from overutilization, routine cardiograms in low-risk patients where the false positive rate is 10 times more likely than in a high-risk patient. And once you get an abnormal test, then you've got to follow it up with another test, and next thing you know, you've got low-risk patients getting caths. Prostate-specific antigen in men over 70. This has been an area of great controversy as people have tried to figure out who should get it, how often they should get it, and why. But in men over 70, they're most likely to have a clinically indolent, slow-growing prostate cancer that is not going to be the thing that kills them. Once you find out and you start down the pathway of do we do surgery, do we do radiation, with all the complications of that, it was better not to even look. Okay, imaging for low back pain. Which has really become a hot topic. And in fact, yesterday, Choosing Wisely Massachusetts launched an initiative to educate patients about the need not to get imaging for low back pain unless there are very clear criteria. Cancer diagnosis, fever of 102, inability to walk, those kinds of things go straight to the CT scanner, okay? But if you just have a very, very, very painful back and you don't have any of those specific findings, imaging does not help, and you're more likely to get surgery. And then bone density for women under 65 or men under 70 with the subsequent drug prescriptions that get given to them. Those drugs cause esophagitis and in some cases actually cause bone loss in the femur or the jaw with fractures. So the standard is don't start until you're 65 or 70. Actual benefit, this is a non-Choosing Wisely study looking at 2009 national data and the top 5 tests and treatments that happen in primary care offices. Routine complete blood count, going in for that annual exam, getting that. Antibiotics for children's viral sore throats, brand name and lipid drugs, annual cardiograms, and a routine urine analysis. Okay, if all that stuff were just stopped, as a screening test, that's worth $5 billion a year in the United States. So now I want to turn to implementation, and this is sort of the engineer part. The next step is really moving beyond making these lists and developing and implementing strategies to reduce the provision of low-value services. Doctors, when looking at this list, think about ways to do this through benefit design. Well, can I make really high copays for these unnecessary tests? Can I have them not covered? Can I do it with deductibles? Physician payment policy, stop paying me fee-for-service, and I may stop ordering some of these things. Professional guidance from our specialty societies. On the other side, engineers can bring to this a systems mindset that doctors don't usually have. Doctors think about the patient in front of them or their own patients, but they don't think very often about the entire system and process of care. So engineers can think about that. They also can develop tools that reliably, prospectively find the low-value care, find the patient about to get the low-value care, and stop it, but do not prevent that care going where it's needed. So looking at some specific tools that systems engineers can bring. Data analysis is fabulous. Most docs do not know how they are doing, do not know how many of these low-value tests they order, do not know how many of their peers order, have never seen a graph like that one with the knee replacements. Most doctors have never seen that. So if we were to look at something like over-ordering tests at annual exams, assuming the annual exam still happens, data analysis would help us identify patients, for example, which doctors do more, which patients get more. Root cause analysis would help us identify what are the reasons that doctors and patients vary from the ideal. And of course, control charts, and especially SPC control charts, can map improvement over time, tell doctors whether they're making statistically significant changes. Quality improvement projects. Most large hospitals have quality improvement departments who are often strapped for the ability to do more. Most doctors' offices don't have anything like this, even large medical groups. What engineers can do is help by developing monitoring and feedback tools and simplifying the work. Reliable design or error-proofing the process. Most doctors have never seen a process map of what happens to a patient or what happens to a doctor in the course of doing something. Human factors design. We all need help with standardizing and simplifying tasks, designing to identify errors so they can be mitigated, visual cues to aid execution, and judgment about where to use human reasoning versus electronic decision support. And finally, decision support tools embedded at the point of decision making. Most doctors still get to the point where they have to make a decision and they've got to go back, log on to something else, find that paper. I only have 15 minutes for this patient, and find the decision support. And it needs to be at the point of decision making. Challenges in healthcare systems. I think non-healthcare-based professionals expect detailed clinical data, and this is pretty much what clinical data looks like. Data comes from administrative claims. Even if we were looking for that patient with the imaging for low back pain, okay, and trying to find the reasons why she or he shouldn't have it, the temperature is in the nurse's notes, the neurologic exam is in the doctor's notes in free text, not in any searchable box. The cancer diagnosis might be in the doctor's notes, it might be in the problem list if the patient has care at this hospital, but if the patient's not at this hospital because they're on vacation, we have no problem list, etc. So it's really not what you guys are used to. Measuring impact is also quite difficult because some recommendations are really complex and the discrete data elements, as in the example I just gave you, are hard to get. There are other people working on this problem at the same time. Insurance companies are producing formularies that say you can only use these drugs, you can't use brand name drugs. Technology management companies, 1-800, can I have a MRI, is out there all the time trying to manage that, etc. And then finally, this requires collaboration among electronic health record platforms, billing software, providers, payers, in order to get the kind of picture that an engineer would ideally like to have. So these are two examples. I am not going to go through them. They'll be available in the slide deck of physician-led choosing wisely projects. The first was at Johns Hopkins in the emergency room where they wanted to cut down on the number of tests that were done for patients who came in and might have a heart attack. And in fact, by the end, they had reduced the number of tests significantly. They had improved doing the right tests significantly. They'd saved a bunch of money. And most importantly, they hadn't harmed any patients. In fact, they found a few more patients that they would have sent out and said, you're okay, you can leave, that actually had a heart attack and they needed to keep. And they reduced the number of patients that they kept in the hospital because they thought they might have a heart attack who didn't. So they did a good job on true positives and false positives. The second one was at Mount Sinai in New York. This was a program to reduce urinary catheter-related infections and the number of days of having catheters in. They simply asked everybody every day, does this patient need this catheter today? And developed a lovely mnemonic for who gets a catheter. So a catheter became an opt-in, not an opt-out process. And once again, they saved a bunch of money and has fewer infections. I want to talk about two projects that we're doing here at Northeastern. They're systems engineering projects, although not choosing wisely. They are focused on reducing utilization. And the first is neurology referrals. And there is an East Coast teaching hospital that gets 125 requests every month for a face-to-face visit to see a neurologist. And the neurologists feel that many of those appointments are unnecessary. So it's a huge economic cost to see patients when they really could be cared for another way. And so the focus of this project was to reduce unnecessary visits. And the process was that the team, and I was not a member of this team, used a variety of data analytic tools to look at both patient characteristics and administrative characteristics of the requests for visits to try to determine predictors. And as you might expect, each of those different methods, and I'll show you those on the next slide, came up with slightly different results. So they sat down and talked to the secretaries and nurses and doctors and said, what do you think? What really makes sense to you from all the results of this data analysis? And developed a tool called a pre-book review. This slide just demonstrates all the different ways of looking at the same data set. And the process of developing a tool. And lo and behold, it was a pretty simple tool. And it was based on simple administrative matters such as who's the referring provider? Is it a primary care, a non-neuro specialist, or a neurologist? And is this a second opinion, yes or no? And so the person at the desk could easily implement this tool. This study is in process right now. This is a validation data set using the tool that I just showed you. And what we see is that a third of the patients were sent to a pre-book review in which a physician looks at the chart in more detail to determine, is there another way to take care of this patient, or does the patient actually need a face-to-face appointment? And 1/3 went to face-to-face. So the sensitivity and specificity of this process can be set in the way that one chooses by altering the choices to send a pre-book review or face-to-face appointment. And at this point, the true positives, which is really the goal, are really showing that only 7 out of 90 got initially triaged correctly into the true positive bucket. So at the moment, a second validation set is going on to determine if this is the right way and to figure out how to readjust this. A quick look at inpatient lab tests. This was done at a West Coast teaching hospital. The goal was to reduce the number of lab tests that were done per admission, or per discharge as it's called, by developing guidelines and process mapping and simulation. And here's a Pareto chart that they did with our friend the CBC as the most commonly drawn lab test once again. And at the end of 3 months, you can see that they had been able to reduce the number of lab tests per discharge by a significant amount. So I want to turn now, before we start with questions, to just a couple more concepts about physicians and engineers together. First, physicians, hospital administrators, patients, policymakers are widely unfamiliar with engineering tools. Secondly, today, at the end of this webinar, we have the opportunity to engage in a dialogue between at least one physician and many engineers to better understand what are the opportunities for using engineering around choosing wisely. And finally, after today, you'll be able to continue this dialogue with your local hospitals and providers and patients about how to use engineering tools and choosing wisely. I want to point out 2 very, very good references. Washington State has produced a number of very substantially helpful materials, both for patients and institutions. And Choosing Wisely has some terrific videos about how a doctor can talk to a patient in a way that's very respectful to engage the patient and walk him or her through this process to get to yes about a test or treatment that the patient wanted may not really be necessary. And I want to give special thanks to Jessica Lewis, who helped in all aspects of this presentation, and finally ask if there are any questions.